I'm Russ Leftwich. Welcome. Glad you can be here. I will take just a moment to introduce myself. It's a tight schedule. So I have been with InterSystems for 10 years as Senior Clinical Advisor for Interoperability. My job responsibility is to be involved with standards development and interoperability around the world and to make sure InterSystems is keeping up with that and that those audiences know that. Before InterSystems, I practiced internal medicine in Nashville, Tennessee for 25 years. And I then was the CMIO for the state of Tennessee for 5 years. I am still on the biomedical informatics faculty at Vanderbilt University Medical School. And in fact, relevant to FHIR, one of my InterSystems colleagues, Pat Jameson, and I delivered a graduate course in FHIR at Vanderbilt last fall. And we'll do that again this fall. It's exciting to talk about FHIR, always has been for me. And things have changed a lot, even in the short time FHIR has been around. 7 or 8 years ago, when I started doing these FHIR workshops, nobody knew anything about FHIR. Now most people know something about FHIR, but most of what people know is not really complete or accurate, partly because we've done such a good job of marketing FHIR. I'm going to try to correct some of those because FHIR is amazing, has a lot of potential, but it is not spray-on interoperability. It is not seamless interoperability because with that, we will get started. There will be a portion starting about an hour from now of hands-on, and you'll need your laptop. That will be an exercise that is not technical, but more instructional to help you understand what FHIR looks like. But I'll start out with what I call the concept of FHIR without being very technical, no more technical than you need to be to use the internet every day. Many of my talks are at professional societies, so I don't have a disclosure slide for this, but I will disclose that the acronym FHIR is part of my vanity license plate. So let me start by going back to when I would point to when the discussion started that led to the development of FHIR. And that was in 1999, the Institute of Medicine, that's now called the National Academy of Medicine, published a report that was called To Err is Human. And it was about safety issues in healthcare and the number of injuries, adverse events for patients. And they pointed out that it was not the kind of injuries that we call oops injuries. It was outcomes that were not ideal, that were bad because the information that was needed to make the right decision was not available at the right time. And that was followed about 2 years later by a report, again by the Institute of Medicine, called Crossing the Quality Chasm. And that report, in its call to action, said that we needed a new healthcare system for the 21st century, a system that emphasizes patient safety, care effectiveness, patient-centeredness, timeliness, care efficiency, and equity. The report also noted differences in quality and outcomes across organizations and providers, differences that could not be explained in the absence of data interoperability. You're likely familiar with William Thomson, Lord Kelvin, who told us 200 years ago, to know something about a subject, you must be able to express it in numbers. I will channel him. If he were alive today, I believe he would tell us to know something about a subject, you must be able to make it computable. That is the goal of FHIR, to make healthcare data computable and create interoperability to solve the quality problems that the Institute of Medicine report identified. Next, I want to describe to you the concept of FHIR. And to do that, I will begin by going back to the 1980s. That's when interoperability in healthcare data began. It began because hospitals started to have more than one system and they needed to connect those systems to each other. Now, the average hospital in the U.S. has over 80 systems and they still need to connect those to one another. Now there is data in many systems beyond the hospital, and interoperability means connecting to those systems and see all of the data for a patient in real time from one place, as it does in other industries. That is today's meaning of interoperability. And not only is there data in more places, as you know, there's a lot more data. And this is a stylized version of a graph from a paper by Dr. William Stead at Vanderbilt a few years ago, where he estimated the number of facts that exist for a complex decision in medicine. His estimate was that in 1980 there were about 10 facts. In 2020, by calculating the growth of data, there were about 1,000 facts. Now there are several thousand facts for every complex decision we make. Not every decision is complex, but most of them are getting more complex. And the thing that hasn't changed since 1980 is the number of facts that a human can handle in their head in making a decision. That is the number 5. I like to think I can do 8 or 9, but I was behind in 1980, and now, like everyone else, I am hopelessly behind. And the only solution to that problem is to make that data computable. And that is really what FHIR is about. In 2010, the organization Health Level 7 appointed a task force and asked them, if we created a new data standard from scratch, what would it look like? HL7 had created version 2, version 3, CDA, and actually 300 other data standards, but it was recognized that they didn't meet the needs of the future. So that task force came back with a proposal that was a concept that we now call FHIR, Fast Healthcare Interoperability Resources. That was meant to meet the needs of distributed data, the need for data liquidity. That was FHIR. FHIR is, in its essence, a REST API, a representational transfer state API. And some of you, most of you may know what that is. If you don't, or if you need to explain it to someone else, I have found that maybe the easiest to understand analogy is travel websites. Actually, everything on the internet is based on REST APIs, but travel websites, if you go to your favorite website and you want to go from Washington to Boston on June the 5th, you put that in and you see a list of flights on different airlines within a few seconds with a price, departure time. That's not because your favorite travel website has downloaded all the airline schedules. It's because the airlines have agreed on how to represent the data in an airline flight, how you ask for it, and what you get back in return. Well, that is what FHIR is. FHIR is the same technology, but it is the meaning of the data in healthcare, and that's where it gets a lot more complicated. As you know, healthcare is incredibly complex and getting more so. To understand FHIR, there are 2 basic concepts. The first is resources. That's resources as in URL. Remember, that stands for Uniform Resource Locator. So a FHIR resource has a known location that looks like a URL. It's on a server somewhere. It's a piece of data. It has a defined meaning. That's the FHIR specification, is the meaning of that resource. And it is a logically discrete data concept, like a patient, a medication, a care plan. It is not a data element. It is everything, every data element you need to define or describe each of those concepts. The second thing to be aware of is FHIR profiles. So FHIR profiles are when we customize a FHIR resource for a particular use case. They are the rules, the vocabulary bindings, the value sets that we need for that particular use case, and they include FHIR extensions, and I'm going to come back in a minute and explain what a FHIR extension is. But FHIR profiles are the rules for interoperability for a particular use case. They are what we create from FHIR. very importantly, interoperability is not in FHIR, it's in the FHIR profiles. So if we define a FHIR profile for some piece of data, then we can use that data in 4 different interoperability paradigms. That has never been true of any previous data standard. So if we, for example, had a lab result that we got from a FHIR REST API according to a certain profile, then we could take that lab result and we could put it in a message and send it to another system just as it is. We don't need to transform it. We could put that lab result in a document and send that somewhere or use it just as it is. We can use that lab result according to that FHIR profile in services like decision support services, because everything in FHIR is inherently computable, machine readable. So FHIR can be used in all of these different interoperability use cases without having to transform it. That's something very special about FHIR. It also means that you can search, you can query for a piece of data. If you know what you're looking for, you can search for that data. I'm not talking about word search. I'm talking about being able to query for a particular type of data from a system because it is computable and because it's expressed according to FHIR. That's something completely different from any previous healthcare data standard. It is said that true interoperability is when we exchange data and we mean the same thing. But it's not us that needs to mean the same thing. It's our systems that need to mean the same thing, and that's where it gets complicated. So let me give you an analogy for that. Suppose 2 people had never seen this animal before, and one of them says it's a white horse with black stripes, and the other one says it's a black horse with white stripes. Well, they'd figure out pretty quick they're talking about the same thing. But to a computer system, those are absolutely not the same thing. Those are 2 different things. And that is where it gets complicated. We have to define everything in very explicit rules for a computer system to understand when we're talking about the same thing. And in healthcare, as you know, there are thousands of zebras that could be described in 2 or more ways that would seem pretty reasonable to a human. So that is the challenge of FHIR. We call those descriptions clinical information models that we would give to a computer system so it understands the meaning of a data concept. All the rules, all the vocabulary bindings, all the relationships between the data, and if that's starting to sound like a FHIR profile, that's exactly what a FHIR profile is. It's an implementable version of a data model. So have we had models before? Well, we have. We haven't talked about it so much. There have always been modelers, but the model we have used in healthcare is the document model. We know the relationships of data because we know what the document represents. So suppose we printed out a history and physical on an individual, and we took a pair of scissors and we cut that into individual data elements, and we pick up a piece of paper and it says diabetes type 2. Well, we know what that is, but we don't know whether it's a condition the patient has, a condition the patient had before they had weight loss surgery and lost 200 pounds, or it's a condition that their mother had and it was in the family history. So FHIR has to recreate those relationships in order for it to be a data model so that systems can understand the data that we're exchanging or representing as FHIR. So as an example of what that would mean in creating what we call a FHIR implementation guide, that is the rules for a particular use case that consists of all the profiles and all the FHIR extensions and value sets that you would need for that use case. We call that a FHIR implementation guide. So for example, if it was for a procedure, it could be a laboratory procedure, an imaging procedure, a surgical procedure. All procedures have certain things in common in terms of a data model. They are all referred to a particular patient. So the FHIR patient resource, procedure resource. What procedure is it? There is a practitioner, the FHIR practitioner resource that formed the procedure. There is a condition, our condition resource, the reason the procedure was performed. And for many procedures, there is a diagnostic report. And there is a counter within which that procedure took place, FHIR encounter resource. All of it be put together as an implementation guide. Talk about the thing that's special about FHIR is FHIR terminology services. So have those value sets and to be able to exchange data, it is important that we have a way to do that efficiently, and that is by taking terminology code systems and representing them on servers the way the rest of the FHIR standard is represented, so that someone who's building something that needs a value set or code system for what they're building can go to the same place and get that value set that everybody else can get it from and share it in that way rather than having to download something to a computer system. So this is one of the ways that FHIR is very different, and those value set requirements, code system requirements, can be part of the implementation guide that you create for your use case in FHIR. I said I was going to come back and talk about FHIR extensions. FHIR extensions are the way we add a data element to a FHIR resource that isn't part of the base FHIR specification. FHIR covers about 80% of what's in all systems in terms of data elements. And the reason that was done was to avoid the FHIR specification getting too complex. HL7 version 3 tried to model everything, and it turned out to be so complicated that people couldn't implement it. So FHIR was going to be kept simple by having this mechanism of adding an extension for data elements that are less common. And as an example, suppose you were a facility that did travel medicine and you specialized in some procedure and people came from different countries to your facility. Well, you would want to know their nationality, but nationality is not a data element in the FHIR patient resource. So you would create a nationality extension that would be an extension of the FHIR patient resource for nationality. And then the other requirement of the FHIR extensions is that you publish, when you send that data, a URL that is publicly accessible so someone who receives that data can discover what that extension means. That is what a FHIR extension is, and it makes FHIR usable in a lot of different use cases without having to know everything about FHIR for your particular use case. A very important thing. And of course, nationality is not a clinical thing, but clinical things work the same way. You add a data element to a FHIR resource for your particular use case. That brings us to FHIR implementation guides, which is sort of the end game of FHIR. It is this collection of FHIR profiles, of terminology bindings, and of extensions that you need for your particular use case. And FHIR implementation guides include explanations, examples of typical use cases that they're intended to be used for, and very importantly, get published using a web publishing tool that HL7 makes available. So FHIR implementation guides get published as a set of web pages, you might say. Not web pages for people to read, web pages for computer servers to ingest and understand that data. That makes FHIR implementation guides a way to validate what anybody who creates data or an application for that use case makes it possible to validate what has been created and confirm that it complies with the FHIR standard and with the profiles in that FHIR implementation guide. That is the ultimate way to assure interoperability. So that's something that is special about FHIR. That's the big picture of FHIR. what to remember when you get home. FHIR resources are a flexible data model that can be applied to many different use cases by customizing them. Interoperability is in the FHIR profiles that are the customization of those resources for a particular use case. That's the interoperability in FHIR. The FHIR specification is machine readable. You can download the whole thing to your server, and everything you create from it is machine readable, and therefore everything that you create from it can be shared. That is an important aspect of FHIR that makes interoperability more feasible. I wouldn't say it makes it easy, but it makes it possible that everything can be shared easily. And FHIR extensions are a way to add data elements to the based FHIR specification without it getting too complicated. FHIR implementation guides are everything you need for a use case. They are machine readable and allow you to develop something that will be interoperable because it is compliant with that implementation guide. And the data that's produced can be validated against that implementation guide as well. Those FHIR implementation guides are machine readable like everything else. HL7 FHIR is open source, freely available to anyone, and it allows derivative works from the FHIR specification, so there are no licensing fees for FHIR. It is open source. The US regulations now require that a FHIR API, according to the US specifications, is part of every certified EHR system. That is something very important, particularly since we have gone from, over the past decade, a little more, from about 10% of US hospitals having EHRs to 97% of hospitals having EHRs, but not only having EHRs, but having certified EHRs that are required to have these capabilities. So that's an incredible transition over about a decade. Next, we're going to take a dive into the FHIR specification. Not that you will come out of here understanding it all, but enough that you should be able to know how to look at it, how to read it, and how to find things in that FHIR specification if you're interested in knowing more after you leave here. Now, navigating that specification, we're going to look at FHIR Release 4, which was published a little over 3 years ago and is what is in the regulations. FHIR Release 5 was published almost 3 years ago, but is not being used because, frankly, the regulations are still in progress rolling out FHIR R4. We'll be talking about FHIR Release 4 and looking at that part of the specification. FHIR resources are a healthcare data model, a flexible one, informed by the HL7 organization having developed HL7 version 2 and CDA, and learning some lessons from developing those standards that have been applied to FHIR. The other thing about FHIR is that the ontology of the FHIR resources recapitulates the functions and services of an electronic health record system, of an EHR. That's important in two ways. One is that is the way FHIR was designed, you might say, but it's also true that EHRs have changed a lot in the decades since FHIR was created. And most of the data that existed, electronic data, when FHIR was created was in EHRs. That's no longer true, and it's getting less true every day that more data sources are actually outside the EHR. So FHIR, in a way, didn't envision what was going to happen in the decade after it was released. So each resource, as we've just talked about, is a self-contained knowledge unit. It contains everything you need to know about that concept, and all of the resources are meant to capture the 5 W's. Who, what, why, when, and where was this data created that is part of this FHIR resource. And it is a complete healthcare information model built through linking these resources. And that's what we're going to spend a lot of time talking about in the rest of the hour and a little bit left today. So FHIR resources, and there are about 150 of them at this point, have different functions or come in different categories. This shows some of the FHIR resources, the ones that we would call clinical data, like medications, diagnostic reports, procedures, conditions, observations, lab results. Those are the clinical resources. But FHIR also has resources that are just basic infrastructure like lists and compositions and documents. FHIR also has process resources that are things like care plans and tasks and care episodes that are not what we would usually call clinical data, but are very much part of the FHIR specification. And then FHIR has a number of resources that you would call administrative resources, all the way from the demographics of patients and providers and organizations to insurance concepts like coverage and payment claims. All of those are parts of FHIR, so it's really everything across healthcare. So let's get in a little bit to navigating that FHIR specification that's openly available. You can log in and look at it and spend as much time as you want. The URL that you enter to get to it is fairly simple, www.hl7.org/FHIR/R4. If you don't put the R4 there, you will wind up on FHIR Release 5 because it's the most recent version. We're working on FHIR R6, which will probably come out sometime next year. But as I said, we want to look at FHIR R4. That simple URL with R4 at the end will take you there. This is the landing page that you come to. There's a red arrow there that points to an executive summary. There's also a summary for clinicians, a summary for developers that you can click on. Everything in the FHIR specification, not everything, many things in the FHIR specification are a clickable link that will take you to an explanation of that particular concept or word. So once again, though, you're reading what was written a decade ago about FHIR, and be aware that the world has changed even since FHIR came along, even if it is still fairly new. You can divide all of the FHIR resources up into modules. This is those, I believe, 13 modules that separate the resources into categories. Once again, the name of each module is a clickable link that will take you to where you can read more about that particular module and the resources in that module. There is also on that landing page for FHIR a graphical representation of those different levels and categories of resources. And this would be where to go if you want to start exploring a bit. This is all of the FHIR resources alphabetically. There are about 150 of them. You'll see that they all have a number after the resource, 0 through 5, or a letter N. Those numbers represent the maturity of those FHIR resources. So the FHIR specification is developed resource by resource, and some of those resources are still a maturity level 0, which means they exist on paper but not in an implementable form. The letter N refers to a concept in standards called normative, meaning that version of the standard you can expect to be stable and no breaking changes will be made in that in the foreseeable future. In the 150 FHIR resources, 13 of them are normative. With FHIR Release 6, over 100 of them will become normative, so it's going to be a giant step, but we'll talk about that at a future workshop. So this is the structure view of each resource that exists, and let me take just a moment to explain what each of the columns in this tree diagram of the resource are. So this is the patient resource. In the leftmost column are the names of each data element, the things you would expect: a human name, a gender, a birth date, and so forth, everything you need to describe a patient. The next column is a flag. I'm not going to try to explain that today. The next thing is cardinality. How many times in an instance of this resource can that data element appear? If it's 0, that means it's optional. If it's 1, then you can only have one birth date, something like that, obviously, obvious to us, but not obvious to a computer. Computer system doesn't know that unless you feed it this specification that some data elements can only occur one time, others can occur many times. So the patient's address, they can have many of them. The patient's name, they can actually have many of them. But that's what cardinality means. The next column, that's a word in blue there, is the data type for that element. And we'll talk in a moment about data types, but if you click on that data type word, it will take you to an explanation of that data type. The next column is the definition or required values for that particular data element. For each data element, you have that explanation of what it is. Zoomed in a little, you can see that there are other data elements that make up a patient resource, like are they deceased, were they one of multiple births, all of the things that you need to know about an individual patient. This is the condition resource, diagnoses, problems, health concerns. That is represented as the condition resource. Importantly, not every condition is a diagnosis. If I say my elbow's tender, that's a condition, but it's not a diagnosis. If a provider determines why my elbow is tender, then that will be a diagnosis. But many of the things we deal with in the course of healthcare that are conditions are not necessarily a diagnosis, but they're all represented as the condition resource. So the condition has a code that is its identity, but very importantly for conditions, you may be able to see there's also a date of onset, a date of abatement if it is in fact no longer an active condition. And there's a clinical status which tells you whether that condition is active or not. Very important to know that somebody's condition is something from the past or it's something current. There's also a verification data element, which means do we absolutely know that this individual has this condition, or is it part of a suspected diagnosis? All of those are very important. They're metadata about this condition, and that metadata will go with the FHIR resource. If somebody retrieves it or you send it to somebody, they don't just have the name of the condition, they have all this other information about that condition as well. Very important about FHIR. Data types, each data element in the FHIR specification has a data type, and it must be represented as that data type. That's part of interoperability. So there are many different data types. We won't go into detail. There are primitive data types like an integer, a quantity, but there are also complex data types which might not seem to you complex, but a postal address is a complex data type because it is indeed a combination of different primitive data types, and it's different in different countries. But each data element has to have a certain data type. That's part of what makes it interoperable. There is a particular data type that I will mention that is important in the FHIR specification, and that's a codable concept. That means when you define a value set for that particular data element, you can choose values that are from different code systems if that's appropriate. It doesn't have to be just one code system, but it also means that a value for that data element can be a string. Maybe there is no code for that. It can be represented as a character string instead. But the codable concept is a key data type for many data elements in FHIR. So we're not going to go into details, but FHIR does have support for coded data of varying complexity, all the way from a string to much more complex data types. And sometimes those things will vary by implementation. So it's not so rigid that you cannot have different value sets or different code systems in different implementations of the FHIR specification. I'll take just a moment to talk about FHIR terminology. As I've mentioned, it's very important. Value sets are very important. And I will use as an example what might seem like an obscure value set, and that's for skin color or skin appearance. Well, it doesn't seem like a profound healthcare concept, but in fact, if you're going to exchange data between systems, everybody has to be using the same code or the same concept for something like a mottled or lividity or redness even. So there is a value set for skin color that allows you to require that value set be used in your FHIR implementation. This particular one is from a breast cancer implementation guide where you want to be able to describe observations about a patient's skin in a very interoperable way. Another data type that is important, and we'll talk more about this a little bit later, is references. References are when one FHIR resource points to another FHIR resource, so they're connected as far as the computer is concerned, like an observation has a patient as its subject. So the observation resource is pointing to this patient resource as if to say, I am this patient's observation. I am this patient's lab test. That's the way FHIR data is represented. Let me take a few minutes to talk about how FHIR is used in organizing data the way we think of it in a patient's record. We talked a bit about the idea of an implementation guide for a procedure, for many different types of procedures, including certain FHIR resources like the procedure resource, the patient resource, the practitioner resource. That's one way we commonly have of organizing data in a patient's record. Those concepts are connected. Organizing things as lists. In healthcare, as you know, there are many lists of things. A patient has a list of medications, a list of problems. A practitioner has a list of patients that they care for or have in the hospital. Many things are lists. Part of making the FHIR specification computable is the idea of there is a list resource in FHIR, and you use that same representation, technical representation of a list, no matter what kind of list you're making, to make the whole computability of FHIR simpler or more straightforward from a programming aspect. So a list resource, there's also a document resource, so that you use the same FHIR resource in different use cases, different paradigms to represent data to make it more computable. This is a story of a child, 12-year-old, who goes to a PCP with an ear infection and then has an allergic reaction to the amoxicillin they're given and goes back for a second visit. So everything in these two visits could be coded as FHIR resources, and they're color-coded in this little story. This is the idea of creating documents out of FHIR data so that you can exchange them and compute with them. If you put all those FHIR resources together, this is a diagram of how those two encounters with this PCP would look diagrammatically, and then you would combine those resources into a bundle of resources. The bundle is also a FHIR resource to send to another system or to send to the patient, or a document is a signed bundle. And of course, the reason it's signed is in healthcare, it's important that the data that we create and exchange is attributed to someone. Someone signed that office note, that whatever diagnostic report is part of accountability, so that it is combined as a bundle of FHIR resources and attributed to a particular practitioner with an electronic signature, if you will. The FHIR questionnaire resource, I will let you know, it is my favorite FHIR resource because I think it has the most potential of any of the FHIR resources. The FHIR questionnaire resource is simply the idea of representing all the data that you're interested in as a questionnaire. Well, as you know, many things in healthcare are questionnaires, from a registration form to a procedure report to a social history. They are all basically forms or questionnaires. So the FHIR questionnaire resource allows you to represent the data in those forms as FHIR resources. The FHIR questionnaire resource has within it the capability of branching logic. So as you know on a questionnaire, and it says if the answer to number 4 is no, then go to number 11. So that FHIR questionnaire resource is capable of that kind of a logical organization, and then it produces a FHIR questionnaire response for each individual that completes the questionnaire. Might be a patient, might be a provider, might be a related person, but it produces a response that is made up of computable FHIR data that can be ingested by another system, can be for analytics purposes, many things, obviously. The way that prior authorization that is being rolled out, some of you may be aware of, when a provider's office has to ask for authorization on some procedure for a patient, the provider will send a request for authorization to the insurance payer. The insurance payer will respond by sending a FHIR questionnaire that is, these are the things we want to know to make this decision. Then the EHR will answer the questionnaire, and as long as the answers are in the EHR, the provider doesn't have to answer the questions. The EHR logic will do so and send the answers back to the insurance payer. So it potentially can be a background process, but it does this by utilizing FHIR questionnaires as a way of getting the data. The beauty of it is you could be asking for any data set that you're interested in as a FHIR questionnaire and send that to another system. This process of having the system answer the questionnaire is called structured data capture. And it has actually been developed fairly far to fill out forms where the EHR answers all the questions that it has the answers to, pre-populates them, and then those that don't have an answer can get presented to a human to finish filling out those answers. But this I see as having great potential for improving data collection, making it easier and more accurate. You can imagine having a questionnaire for a registry submission as well. The data that you want for your registry is a FHIR questionnaire that you send to another system. Or great thing about it is you could send the same questionnaire to multiple systems if you don't know exactly where all of that data is. Talking a little bit about exchanging data, FHIR bundles are bundles of FHIR resources that you want to send as a bundle, which is exactly what it sounds like it is, a bunch of resources together for some particular purpose. It's a lab report. It's a bundle that has the patient, the laboratory that performed the lab test, and the results of all those lab tests in a bundle. And they get sent together to another system. Occasionally you might store bundles, but usually they are for exchanging data. The other thing that bundles are used for, and this is a little bit not intuitive, but if your system is creating data on a patient as FHIR resources. And you create, say, the stages of a patient's condition where it's suspected and then it's confirmed and then it's being managed over time and maybe it resolves, it goes away. You don't create a new FHIR resource every time that you create a new version of that condition resource. You just create a new version that has changed by whatever changed, and then you can query that system in the future for what's called a history bundle. In other words, for this particular condition, this particular lab observation, what is the history in this system of all the different changes that have been made? And that comes as a FHIR bundle. Something that we're not going to talk about in great detail is what I have already explained is really the key thing about FHIR, and that's creating FHIR profiles. So FHIR profiles are when you customize a resource for your use case. You may limit the number of some data element. You may require a certain value set. Give you a simple example of a profile for the FHIR patient resource. Suppose you're the NHS in the UK. Everybody in the UK, as you may know, has a NHS number. They don't have medical record numbers in different hospitals. They have one number that's used everywhere. If you were creating a FHIR patient profile for the NHS, you wouldn't allow people to have any number of medical record numbers, which the FHIR patient resource does allow. You would want everybody to have only one patient number, and that's the NHS number. That would be a FHIR profile. That's a bit of a simplistic one, but they all work the same way. You change what value set can be in a data element or how many times that data element can occur. So with that, we're to the hands portion of the exercise. You will need your laptops with a browser. I have a script here with step-by-step instructions, which if you don't keep up with this, that's okay. You can take this home. The web app we're going to use is freely available, and you can play with it at home if you're so inclined with this script. Now, I will be playing for you in a moment me doing this exercise on screen, but this way you don't have to watch me type and talk at the same time. If you don't keep up, that's okay. Don't worry, if you miss a step, you won't break anything. And this exercise uses a web app that is called FHIR. It's at clinfire.com. It's freely available. It was created by Dr. David Hay in New Zealand. And this particular scenario is a patient with a condition and a lab test that's ordered, and the ordering of that lab test and the creation of the hemoglobin result of that lab test. This web app is a way of visualizing what FHIR resources look like. It's not an app development environment. It's a FHIR data modeling environment that helps you understand what FHIR data looks like. Now, I have had these Meta AI glasses specially modified so that I can see in a FHIR server and see the FHIR resources. My budget request to get everybody a pair of these for the workshop was turned down. But what you will see with the app is what I see with these glasses on, the way FHIR resources look if you can look into a FHIR server. So the app is a part of this larger suite of tools called ClinFHIR. This app is called Graph Builder 2. It's not a FHIR app. What we're going to do today is a bit tedious. That's not the way FHIR apps are. That's the way this app shows you how things work. So don't mistake this for being the way FHIR works. This is about how you understand FHIR, not about how it works. But it is really a remarkable little web app. Developers use it when they're developing FHIR apps, because if you think about it, if you had an idea for a FHIR application in your work environment, in whatever area you're in, the first thing you would do is sit down and write down what data do I need to access, or what data will my app create. And then the next thing is, how would I represent that data as FHIR? Well, that's exactly what this ClinFHIR tool helps you to do, is to model the data you're interested in as FHIR resources. So now we're ready to begin the hands-on portion of the workshop following the numbered script. Start by opening a browser and typing into the browser window https://bit.ly/ready26lab. Ready is capitalized. That should open the Graph Builder 2 app with a library window showing the Ready 2026 lab order exercise. Click on the green Download Project button. That will open the home page of Ready with a project in the upper left corner labeled Ready 2026 Lab Order. If you click on that title, that will open the project. You will see a graph with 11 colored boxes, each representing a FHIR resource. This has been pre-populated to save time with the patient in our scenario, the practitioner, Dr. Phil Primary, and the practitioner role, which is a separate resource, a certified nurse technician who is a phlebotomist as another practitioner, and the organization she is affiliated with, Amazing Health Labs, the patient, I'm a patient, and 2 condition resources, an encounter, which is an office visit, an observation resource for the hemoglobin level. Each of these FHIR resources are resource instances that contain no data. We will be adding that data during this exercise. Those labels you can think of as sticky notes on the resources to remind us what we're going to do with them. The labels are not actually data. Now, adding new resource instances. This is how you would start if you had a blank screen, or how you can add instances of resources to a scenario. Number 7, use the green Add a New Resource Instance button in the upper right corner to add a condition 7A. Click on the green button, type into the filter box condition, and in the display, suspected anemia for the condition. Save that. The green button again. 7B, add a service request. And this is to order the hemoglobin test. Save that. The green button again. And a task resource. A task is any activity in the course of healthcare, including both clinical and administrative, as well as laboratory tests. This will be the specimen collection for phlebotomy. Save that. And one more resource, the specimen that is collected. So this will be venous blood. Save that. those have been added to the graph. You can see that you can manipulate the graph with a mouse or trackpad. I'm going to move a few of these resources for visibility's sake. Okay. References between FHIR resources are a key concept in understanding the FHIR data model. Number 8, click on the References tab above the graph to see a list of the resource references. In the left column are the FHIR resources in the graph, and in the right-hand column, the references from that resource to other resources. Graph Builder 2 only allows one subject, one patient in a scenario, so it has assumed that the patient is the subject of all of the condition, observation, and encounter resources in the scenario. Adding references to a resource. Number 9, click on the Content tab and then click on Asthma. Click on the Details in View tab in the right panel, which may already be clicked. And number 11, below this, click on the Potential References, which also may already be clicked. If you hover the mouse over the items in the left column, you will see an explanation of what each of those is. Number 11B, click Add Reference next to Encounter to associate this condition with the single encounter that's in our scenario. 11C, who recorded the asthma condition? That would be the practitioner, Dr. Phil Primary, although it could be the practitioner role. And last, who is the asserter of the asthma condition? In our story, that was the patient who told the PCP that they had had asthma in the past. So in this case, they are the asserter. That is added as a reference. If they had been diagnosed with asthma, then the practitioner would be the asserter. So now all of those are filled in the middle window as FHIR shorthand code. And if we click on the graph, we see that those arrows have been added to the graph, indicating those references. Very important to note that if this data is accessed, exchanged, or sent to another system in the future, all of those elements of metadata will go with it, not just, for example, the name of the condition, but who recorded it, who asserted it, and in which encounter was this recorded. Okay, another pause between slides. Anybody have a question? Next, adding values to elements using the FHIR Shorthand Editor or FSH Editor. The FHIR Shorthand Editor is a human-friendly editor for the content of FHIR resource instances. It is used by developers to develop FHIR profiles and FHIR implementation guides, but our use here is going to be limited to this educational activity. Number 13A, double-click on I'm a Patient. This will bring up the FHIR Shorthand Editor with a screen showing the names of the data elements in the left-hand column, the cardinality in the next column, and the data type in the third column. When you click on a data type, it will open a dialog to enter values for that particular data element. Start by clicking human name, the third item, and then enter the name of the patient, the given name, the family name, and the use. If you click, you'll get a drop-down list. We'll make this official. You'll see other possibilities. Now click Insert. 13B, click on Reference next to General Practitioner. You'll see a window with choices. You can either make the general practitioner an individual practitioner, or in this case, I'm going to choose the organization Amazing Health Clinic as this patient's general practitioner. That is inserted into the FHIR shorthand code in the middle of the screen. 13C, give the patient an identifier. This would be a medical record number. You'll see that the cardinality allows more than one of those. The system will leave blank, but that would be the organization that is assigning this number. Make up a number and enter it into the value screen. Insert that. 13D, click on the JSON tab. In the middle, you'll see that it is empty. Click the double circle arrows at the upper right. That will generate JSON code. Now click Save. Now you'll see in the graph the arrows that have been added, including one between the patient and the general practitioner you chose. Number 14, double-click on the condition asthma, which should be somewhere near the bottom of the graph, to again bring up the FHIR shorthand editor. Click on Codable Concept across from Code about the 6th line down to open a dialog box. In the filter string box, type asthma and then click Expand. You'll see this brings up a long list of codes. They are SNOMED codes that include the word asthma. We don't know details about this patient's asthma, so we'll select the first, which is a generic code for asthma. But note there are over 30 other codes, and this is an indication of why we need value sets to be used as drop-down lists, among other things, because the chances that two different practitioners would choose the same code for an individual patient's asthma are not very high if you gave them all these choices. That is now inserted into the FHIR shorthand code in the middle of the screen. 14A, click Codable Concept next to Clinical Status, then click the Expand. This shows a preferred value set. The patient has indicated they have not had any asthma for about 5 years, so we will select Inactive, and that's inserted into the shorthand code. 14C, click the Save button, then click on the Resource Content tab. In the right panel, you'll see the FHIR shorthand code there. Click the JSON tab, which should be empty, and now click the double circle arrows at the very upper right. Generate JSON code. You'll see code appear in the window as well as a all good indication. This means that this app has gone out to a FHIR server and validated that the code we have created, the instances we have created, are valid against the FHIR specification. This is a very important capability of the fact that FHIR is all machine readable. Next, adding values to add clinical context. Number 15, double-click on exercise intolerance condition, which should be near the bottom of the graph. In the FHIR shorthand editor, click on Codable Concept next to Code. I want to use this as an example of how difficult it is to create semantic interoperability by finding a code for the wide variety of terms a patient might use to describe symptoms or concerns that they have. In this story, the patient said they had exercise intolerance, which is easy to understand. They were fatiguing, getting tired with exercise more than previously over the past few months. If we enter the term exercise intolerance here, I can tell you it will not produce a code that means anything like that. You can do that sometime if you're interested. What I have discovered with a bit of experimentation is that if we enter worsening exercise tolerance, click expand, there is a SNOMED code for that concept, worsening exercise intolerance, which I think to most people would be equivalent to increasing exercise intolerance, but in fact, there is no code for the latter. I'll select that, click Save. So interoperability is hard, and I'm not sure AI is going to solve some of these problems. If there are 30 different codes for asthma, it's hard, and exercise intolerance sounds like worsening exercise tolerance to me, but it is hard sometimes. Now you should be back to the graph. The next section will demonstrate one of the workflow resources in FHIR. We spend a lot of time on the what you might call static resources like observation and condition, but there are other resources related to healthcare workflows, including administrative ones. This particular example might be something that would be outside an EHR as an app. So number 17, 17A, double-click on the service request for hemoglobin, and 17B, click Code by Status. Note that status has a one-to-one cardinality, meaning it's a required element, must have only one value. For our example, we will make the status completed. 17C, another required element, the intent of the service request, which in our example is, of course, to order a hemoglobin level as a lab test. Clicking on code next to intent. The intent is an order. Insert that into the FHIR shorthand. 17D, click on Codable Concept next to Category and click Expand. Click the SNOMED code next to Laboratory Procedure. 17E, click on Codable Concept next to Code. Enter into the filter string box total hemoglobin and click Expand. We see a list of codes and the fourth one down, measurement of total hemoglobin concentration in plasma specimen. I will choose that one. I will note that there might be instead a LUNC code used for this particular value, but the Graph Builder tool has been populated with the SNOMED codes. 17F, click on Reference next to Requester. You may need to scroll down for that. Your requester, of course, the practitioner, Dr. Phil Primary. 17G, click on Reference next to Performer. This test is, of course, going to be completed by the Amazing Health Labs. Select that organization as the performer. 17H, click on Reference next to Reason Reference. Again, you may need to scroll down for that. In the data elements, the reason may be a coded value, but in our case, we're going to use the suspected anemia condition as the reason. I will select that. That's inserted into the FHIR shorthand code. 17I, click on Reference next to Specimen, and we have only one specimen in our scenario, so select that venous blood specimen. That's inserted into the FHIR shorthand code. Number 18, click Save. Click on the Resource Content tab to the right. Click on the JSON tab if it's not already clicked, and click the double circle arrows to the right to generate JSON FHIR shorthand, and you see we get an all good indication along with our JSON code. And you'll see that these additional references, arrows, have been added to the graph in the middle panel. Number 19, double-click on the task resource for the specimen collection and see the list of data elements for the task resource. I'll scroll down, display the rest of the data elements. Because of our limited time, we're not going to take time to actually populate these data elements. The task resource is used for a broad variety of tasks, any activity which might be assigned to practitioners, the related persons, or the patient. So we'll click Cancel. Now for the final section, representing lab test result with the observation resource. Number 20, double-click on the observation hemoglobin level. Open the FHIR shorthand editor. 20A, click on Codable Concept next to Category, and then click Expand. Laboratory Category, select that. 20B, click Code next to Status. Note that this is a one-to-one cardinality, a required data element, a required value set. We'll select Final, Insert. 20C, click on Codable Concept next to Code. Also one-to-one cardinality, a required data element. This is the identity of the test. Enter hemoglobin in the filter string box. Expand and see a list of LUNC codes for hemoglobin. Simply select the first, and that is inserted. Number 20D, click on Reference next to Encounter. And since we have only one encounter in the scenario, select the office visit. Click on Date Time next to Effective. This is the time the specimen was obtained. Enter a date only in the interest of our time and insert that. 20F, click on Reference next to Performer. And the performer, of course, is Amazing Health Labs, the organization. Select that. Number 20G, click on Quantity next to Value. So you can see there are several different possible data types for value. Enter the 10.2 and the units grams per deciliter. This is a low hemoglobin. Click Insert. 20H, click on Codable Concept next to Interpretation. This is a low value, so enter low and click Expand. You see there are several choices for low. I'll click Significantly Low. Now, click Save. Click on the JSON tab and click the double circle arrows to generate JSON, and we get an all good indication. Now, the graph, you will see all the references, all the arrows that we have now added to complete this graph. Now I would invite you to stand up, raise both arms in the air, and shout FHIR. FHIR APIs and servers, and what FHIR has taught us about the data that's in our EHR systems, and that the real challenges of interoperability and working with the data that's there, and a bit about semantic interoperability, since that is the goal of implementing FHIR and interoperability in our system. FHIR, we hear it called an exchange standard. It was really created, the primary intent was to be able to access data in different EHR systems and have it look the same way. So you don't have to know how that system stores its data in order to get the data out. That was the primary intent of FHIR. You have to do that before you can exchange data, but this is one of those marketing messages that you hear so often that it's not really accurate. Before you can exchange it, you have to access it, and that was what FHIR was really created for, to access data so that it would be consistent when you took it out. That turns out to be even harder than it sounds. The other thing that a lot of people wrongly assume when they start to learn about FHIR is that there's FHIR in EHR systems. There is not. And FHIR is not always the way data is stored, even if it's the way data is presented to you when you query a system. First, many of you may know this, and it doesn't always make much difference, but the difference between FHIR API and a FHIR server. A FHIR API is the communication between a client and a server, and the server is the logic, the software that stores and retrieves the data. So there is a subtle difference between the two, even though we often refer to them as if they're the same. And FHIR is a representational state transfer application programming interface. That's sort of the basis of it. It's not strictly adherent to the rules of such, but that's the way we refer to it. So the FHIR REST API is the interface specification defined as part of the FHIR standard. So that is explicitly defined in the FHIR specification. The functions of a FHIR API, well, one is to publish a capability statement, and I'm going to explain exactly what that is in a moment. The FHIR API usually implements FHIR RESTful interactions, create, read, update, and delete data. Search allows you to search and query for data using filters. It creates that history and versioning that I referred to earlier, where there is actually a history of different versions of a FHIR resource in the server that you can retrieve as a bundle. FHIR APIs validate the data against the specification. As we saw in the hands-on exercise, you click and it tells you that the data you've created is valid, and FHIR servers can be implemented in different formats, JSON, XML, and Turtle, and they can accept transaction bundles, which means you send a lot of data as FHIR and it updates that data in that server, or you request a lot of data and you get back a bundle of data in response to your request. And FHIR servers have custom operations that they don't all have. Those operations are not required in the FHIR specification. The definition of a FHIR server is any software that implements all or part of the FHIR REST API and uses FHIR resources to exchange data. So it must be able to accept FHIR resources, and it must provide FHIR resources in response to a query or operation. The only thing that a FHIR server must do is publish a FHIR capability statement. A FHIR capability statement is a machine-readable statement of what this server does. So what release of FHIR is it? Is it release 4? Is it release 5? And so forth. What profiles can this server validate against? What operations is this server capable of. That is a machine-readable representation of everything this particular server does, and every server must publish that. Everything else it does is optional, but it has to have a FHIR capability statement. So if you're a FHIR client, the first thing you do is query that server to find out what its capabilities are. The difference between a FHIR server and a FHIR repository is something that a lot of people get confused about when they first learn about FHIR. And some people remain confused about that. But a FHIR server, we have said, exchanges data as FHIR, but a FHIR repository stores data as FHIR. A FHIR server is not necessarily a FHIR repository because it may store its data in some other format. We call that a FHIR facade. So a FHIR facade is a FHIR REST API that does not have a FHIR backend. In other words, no FHIR repository. That data is stored in some other format and schema, or it's not stored at all. So a server does not have to store data necessarily. And bulk FHIR is something we haven't talked about. Bulk FHIR is not a REST API. Bulk FHIR is a format to represent large quantities of FHIR data, like hundreds of patients and a certain set of FHIR resources for those hundreds of patients, or maybe hundreds of FHIR resources for a single patient. But it's a large collection of data. It uses a different format from the REST API that we've talked about. But the REST API is a very inefficient way to do population health or cohort data, where you want data on a lot of individuals or you want a lot of FHIR resources, because each one of those FHIR resources is an operation, a REST operation, and that becomes very computationally heavy if you're trying to get a lot of data that way. So bulk FHIR does it as a batch, looks like a table of data, and it is a batch API as opposed to a REST API. And EHRs, as of 2023, certified EHRs in the US, are required to be capable of sending FHIR bulk data. They don't have to receive it, but they have to send FHIR bulk data in response to a query. Bulk FHIR is for populations, cohorts, for analytical data sets, for collecting data from multiple systems to be aggregated as data, like for insurance plans who have members that have data in different systems. It does allow you to update just specific data that has been updated since you received that batch, so you don't have to start over and get the whole batch again. And as I said, it's required for EHR certification in the US as of 2023. I mentioned some of the uses of it. Public health is a particular use case because biosurveillance usually needs data from large populations of patients. What is different about some individuals in a large population? Insurance carriers who want to expose claims data from systems. FHIR has taught us a lot about data in the EHR systems that we should have known was complicated, because that's sort of where we started with those reports from the Institute of Medicine that I mentioned. The data in EHR systems is not the same, even if we would like it to be. EHR systems are like snowflakes. They are all different, more so than you would think. They're different versions of that EHR brand. There are always customizations when you implement an EHR. There are connections to different departmental systems. Different hospitals have different laboratory systems. Sometimes they have more than one laboratory systems, but the EHR is connected to different systems, different pharmacies. They have different pharmacy formularies. They use different local terminologies. I don't know how many of you are involved in a healthcare organization or particularly lab system. They have their own terminology that they use for a lot of lab tests. And terminology vendors overlay their terminology on top of the EHR. And most of all, probably, and this is where we started, why do patients have different outcomes at different organizations or by different providers? Because there's variation in the practice, and variation in practice, you cannot expect to produce the same data in different EHR systems. So this article, it's about 3 years ago now, I think, was published, and it tells you a lot. And it was not about FHIR. It was a group of, most of them were oncologists, gathered data from 68 different EHR implementations that included 5 different brands of EHRs. Cerner, Meditech, Epic, Allscripts, so 68 different EHRs. And they looked at 12 different data items in those EHRs. 6 lab tests and 6 medications in all of those 68 EHRs. And what they found for those 12 items, just 12, the correspondence index for those 12 items, if the 2 EHRs were the same brand, was 0.68, just for 12 simple things. And this is raw data, no FHIR here, just the data that's in the EHR. If they looked at those 12 data objects for 2 different EHR systems, the correspondence index was 0.22. So the data that's there to begin with just isn't that similar. Once again, there is no FHIR in the EHR. There is a FHIR API in a certified EHR because it's required to have one. So what happens if you query that FHIR API for some FHIR data? The EHR converts that query into its internal logic. It goes and fetches the data where it thinks it is going to be stored. It converts that data into FHIR and answers the query. There was no FHIR in the EHR. This is some logic that has been created to answer that query from the proprietary schema that EHR uses, presuming nobody has customized the part that has the data that you wanted. So it is not seamless as the marketing language wants us to believe. So why not convert all the data in the EHR to FHIR? Well, that would just be inefficient because most of it would never get accessed. FHIR is an access standard, not a storage standard. And the truth is that FHIR profiles cover only a small portion of the data that's in an EHR. The must support data elements of the US core FHIR profiles, must support data elements means that to be certified, you have to support these data elements. There are only 406 must support data elements in the US core FHIR profiles. Most people's guess at how many data elements are in an EHR, 50,000 to 60,000. So it's important, 406, but it is not everything, and converting everything would not make any sense. So let me finish by talking about semantic interoperability for a bit. Syntactic interoperability is when the format and structure of the data are shared between systems and it's consistent. That's HL7 version 2. Semantic interoperability means the ability to understand the data and to use it by the receiver. There's process interoperability, but I guess the ultimate interoperability that we would talk about is clinical interoperability, meaning a practitioner of the same specialty taking care of the same patient could get the data from another system and continue that patient's care without any changes. That's the idea of clinical interoperability. That's a very big challenge. So semantic interoperability, the data has the same meaning down to a very specific a consistent definition of the data elements in it, and it can be implemented in different standards, not just FHIR. Syntactic interoperability means that the data has the same structure and that the data exchange is standard. So a real-world example of how hard it is comes from Dr. Linda Bird, who's in Australia, several years ago looked at 3 different EHR systems and one data concept and how it was represented in those 3 different systems. And the concept was suspected lung cancer. One of those systems represents this concept as probable cancer body site lung. Another one of those systems represents it as suspected lung cancer. And the third system uses a SNOMED code that means suspected lung cancer. 3 different ways of representing the same easy to understand concept. The different systems used 6 different SNOMED codes in representing the data in their system. And of those 6 different codes for these 3 systems, only 2 of the SNOMED codes were the same across the different systems. So that's how hard semantic interoperability is. So we're back to the zebra. How is it a white horse with black stripes or a black horse with white stripes? And the challenge is that you can create a FHIR profile for either version of the zebra. You can create many FHIR profiles for the same use case, the same concept, but they're not the same. And it's only interoperable if your 2 or more systems do use the same FHIR profile. And the situation that we have seen develop over the past decade is that different people are creating different FHIR profiles for the same thing, and they are not interoperable because they are different, semantically different. So this is a problem yet to be solved. Some people who have been thinking about this a lot think that we need library of those definitions, of those clinical element definitions, and that we share the same library and everybody uses the same definition. That would be a solution. Maybe AI can help us with this. I think it's not an easy problem to solve. In your organization, though, you may not have to solve that problem at the highest level to implement useful things with FHIR. That is, in fact, one of the great things about FHIR questionnaires that I didn't mention when I talked about them before, is that FHIR questionnaire doesn't really need to be interoperable across the country. If it's just interoperable in your organization, it can be very useful. So, to sum up, FHIR resources are a flexible data model. Interoperability is in the FHIR profiles, and the FHIR specification is machine readable. That makes it easy to share things and validate the data that we have. FHIR extensions make it possible to create useful implementations for a specific use case without having to pay a lot to customize your EHR. And FHIR implementation guides are the real rules of interoperability that we're able to share and implement. The U.S. regulations at this point require a FHIR API on certified EHRs, and 97% of hospitals have certified EHRs. To say that they're at optimum use at this point would be not reasonable at all, but I think it will get better. Population and big data require something different. That's bulk FHIR. Bulk FHIR was not part of the FHIR specification originally. It was added a few years in with the realization that the FHIR API was not a way to do big data or population health. EHRs are FHIR facades. There is no FHIR in the EHR. And the challenge ahead is really deciding how we're going to agree on a single interoperability model for each use case. Thank you. We did wind up with a few minutes for questions or comments. Yes?
Are the R's, the revisions of FHIR backwards compatible or do they break previous versions?
The releases of FHIR are not backwards compatible.
Okay.
That's what normative means, that designation that is only 13 of the resources at this point, but will be a lot of them. And there was a decision made that the next release of FHIR, release 6, will be all normative.
So in other words, you need to support each R4, R5, R6 separately. You can't.
Right. But it means that you can invest in R6 and it won't change. Whether not changing in today's world is a good thing or a bad thing is what I'm not sure about. FHIR, I always appreciated the fact that FHIR was built to be able to change, to try it and change it where it didn't work. That was a good thing. I have always thought of FHIR as something like the iPhone. You know, you get this year's model and you use it, and you know that next year's model will have some new features and some of the things that didn't work will be fixed. I kind of like that idea of FHIR.
Or it's additive.
But there is said to be a lot of pressure to pick something that's not going to change for a while. I do think AI will help us with some of this stuff. I'm hopeful that AI will be able to help us tell us what we've never been able to figure out, and that is, how is that healthcare organization's data different from that healthcare organization's data? We naively, a decade ago, thought it was going to be the same if we just got everybody to implement FHIR. It didn't turn out that way. You know, we thought a decade ago there was going to be a FHIR app store. Well, it has never happened, and I don't think it's likely to because of this. Your data is really not the same as my data is. And that's not anybody's fault. That's just the reality, the complexity of healthcare.
Sorry, last question. Is there a data standard, storage standard? That's FHIR is the access. You mentioned access versus storage. Is there any data storage standard out there to try to tackle this?
No, I mean, people have proposed that might be a solution, but that would mean everybody would have to agree on that. And that would mean that the proprietary schema that each EHR vendor has developed, that they would have to agree to either let everybody use theirs or use the same one. That just seems impractical to me. And I'm not sure we could get to a universal storage format very easily. I don't know. Maybe AI will figure that out for us. I do think it will. You know, we're already able to solve a lot of problems, or at least solve them more quickly, and we're just getting started. But the problem is we're humans and we're different, and we describe our symptoms differently. We don't even know if they're the same. If you and I are experiencing the same symptoms when we call them the same, you know, it's complicated, but I do think we've made progress. I think now is a good time because I think we're just at the point that we can really start making use of some of the FHIR capability and making use of it outside the EHR. We have been kind of confined by the EHR over the past decade. I think there's a lot of potential if people understand FHIR, meaning all of us, for us to go in our work area where we understand the problems better than others do to create something useful. I think FHIR has tremendous innovation potential, and I think AI is going to help people who aren't coders, who aren't developers, develop stuff. It's already starting to happen. If you can tell it what you want it to do, tell AI what you want it to do, it does the coding pretty well and getting better fairly fast. Well, thank you for